Hello, my name is Jones Muna. Today, we look at wound healing. Forms of wound healing. 1. First intention. 2. Second intention. First intention, primary, healing occurs when tissue is cleanly incised and reapproximated and repair occurs without complication. Second intention, secondary, healing occurs in open wounds through formation of granulation tissue and eventual coverage of the defect by spontaneous migration of epithelial cells. Most infected wounds and burns heal in this manner. Granulation tissue is the red, granular, moist tissue that appears during healing of open wounds. Microscopically, it contains new collagen, new blood vessels, fibroblasts, and inflammatory cells, especially macrophages. Primary healing is simpler and requires less time and material than secondary healing. It sometimes happens that primary healing is possible, but there is insufficient reserve to support secondary healing. E.g., ischemic limb may heal primarily, but if the wound opens and becomes secondarily infected, it may not heal. Healing phases. Injury profoundly disrupts the chemical environment and architecture of tissues. The post-injury environment, characterized by impaired perfusion coinciding with inflammation, invokes a number of fundamental biochemical, physiologic, and cellular coping mechanisms in process of healing. Process includes coagulation, inflammation, fibroplasias and matrix deposition, angiogenesis, epithelialization, contraction. Cells involved are platelets, leukocytes, especially macrophages, fibroblasts, vascular endothelial cells, and epithelial cells. Signals that direct them: cytokines and growth factors as insulin, insulin-like growth factors, IGFs, transforming growth factors, TGFs, fibroblast growth factors, FGFs, leukocyte-derived growth factors, LDGFs, platelet-derived growth factors, PDGFs, and EDGF. These molecules may also behave as chemoattractants, inhibitors of differentiation, and stimulants of specific protein synthesis. In higher doses, they may be cytolytic. Cytokines include interleukins 1, 2, 6, and TNF-alpha. 1. Coagulation and inflammation. Clotting of blood contributes the first reparative signals. Fibrinopeptides, fibrin, thrombin and platelets released PDGF, IGF-1, and TGF-beta attract other inflammatory cells, especially macrophages, into injured tissue. Inflammation begins as damaged endothelial cells release cytokines, which induce integrin and integrin receptor expression in passing leukocytes. The leukocytes adhere to local endothelial cells and enter the injured extravascular space attracted by tissue complement factors, fibrinopeptides, growth factors, and cytokines. Initially, inflammatory components such as histamine, serotonin, and kinins cause vessels to constrict as an aid to hemostasis and then to dilate a short time later. 4. Epithelialization. Epithelial cells respond to many of the same stimuli as do fibroblasts and endothelial cells. A variety of growth factors regulates replication. TGF-beta, for instance, tends to keep epithelial cells from differentiating and thus may potentiate and perpetuate mitogenesis, though it is not itself a mitogen for these cells. TGF-alpha is an epithelial cell mitogen. Mitosis appear in epithelium a few cells away from the wound edge. The new cells migrate over the cells at the edge and into the unhealed area, perhaps attracted by a growth factor or cytokine, and anchor on the first unepithelialized place, forming a new wound edge. The PO2 on the underside of the cell at the anchor point is likely to be low. Low PO2 stimulates squamous epithelial cells to produce TGF-beta, presumably hindering terminal differentiation and favoring mitosis. This process repeats itself until the wound is closed. Squamous epithelialization and differentiation proceed maximally when the local PO2 approaches about 700 mm Hg, and when surface wounds are kept moist, even short periods of drying can impair the process. The exudate from acute, uninfected, superficial wounds also contains growth factors, lactate, and therefore recapitulates the growth environment found internally. 5. Collagen fiber maturation, lysis, and contraction. Replacement of an extracellular matrix is a complex process. First, fibroblasts replace the provisional fibrin then extracellular matrix with collagen monomers. Extracellular enzymes, some of which are PO2 dependent, quickly polymerize these monomers, but in a pattern that is much more random than normal, thus leaving young wounds weak and brittle. This brittleness is overcome when the hastily placed matrix is replaced with a more mature one consisting of larger, better organized, stronger, and more durable fibers. Fibroblasts and leukocytes secrete collagenases that ensure the lytic component. Turnover occurs rapidly at first and then more slowly. Even in simple wounds, increased turnover can be detected chemically for as long as 18 months. Healing is successful when a net excess of matrix is deposited despite concomitant lysis. During inflammation, vessels become porous and release cells and blood plasma into the injured area. The newly arrived inflammatory cells increase metabolic demand. Since the local microvasculature has been damaged, PO2 falls, while CO2 and lactate accumulate. Lactate and produce more vasodilatation and attract more inflammatory cells. Vicious cycle is thus set with macrophages taking the role of releasing chemoattractants as coagulation-derived factors decrease. Macrophages release more lactate even in the presence of oxygen, thereby maintaining the environment of injury. The environment causes them to release growth promoters and more lactate, which in turn stimulates angiogenesis and collagen deposition. By second-3rd day, unless the wound becomes infected, its granulocyte population, which dominated on the first day, has diminished. Macrophages now cover the cut surface. In 3rd to 4th, immature fibroblasts, the product of growth signals, lie just beneath, mixed with bud of new vessels. More mature fibroblasts are scattered behind. 2. Fibroplasia and matrix deposition. Fibroplasia. Replication of fibroblasts is stimulated by PDGF, IGF-1, and TGF-beta, released by platelets, and continuing with cytokine released by macrophages. Fibroblasts appear to release IGF-1. EGF and IGF-1 are also delivered by blood. Fibroplasia is mainly near the wound edge, where they are exposed to the growth environment and to a higher oxygen tension. Smooth muscle cells are likely progenitors of fibroblasts, as they seem to stream from the adventitia and media of vessel. Matrix deposition. Replicated fibroblasts secrete the collagen and proteoglycans of the connective tissue matrix that weld wound edges together. Both assume high molecular weight polymeric forms and become the physical basis of wound strength. Some growth factors, TGF-beta and IGF-1, promote collagen gene transcription. Accumulation of lactate in the extracellular environment directly stimulates transcription of collagen genes as well as synthesis and deposition of the protein itself. 3. Angiogenesis. It becomes visible about 4 days after injury, but begins 2 or 3 days earlier when new capillaries sprout out of pre-existing venules and grow toward the injury in response to chemoattractants released by platelets and macrophages. In primarily closed wounds, sprouting vessels soon meet counterparts migrating from the other side of the wound, and blood flow across the wound is established. In unclosed wounds or those not well closed, the new capillaries fuse only with neighbors migrating in the same direction, and granulation tissue is formed instead. Wound angiogenesis appears to be a response to local energy depletion, hypoxia and lactate accumulation. Dynamic splints, passive or active stretching, or insertion of flaps containing dermis and subdermis may be needed to counteract contraction. The force can be quite strong, though even severely contracted joints can usually be straightened with counter-traction. Contraction occurs as long as collagen deposition is active, and chronic, slowly healing wounds, as in ischemic tissues, are particularly likely to contract. Prevention of a stricture in a ureteric repair, for example, depends on ensuring that the opposing tissue edges are well perfused so that healing can proceed quickly to completion. Healing wounds may also stretch during active turnover when tension overcomes contraction. This may account for the laxity of scars in ligaments of injured but unsplinted joints and the tendency for hernia formation in abdominal wounds of obese patients. 6. Completion of healing. Normally, the final stimuli to release of growth factors and cytokines seem to be local hypoxia and lactic acidosis. When these stimuli disappear as the new microcirculation matures, healing should stop. Keloids, local overgrowths of connective tissue, and hypertrophic scars, which occur particularly in pigmented skin, probably represent a loss of normal control over the healing process. Factors impairing healing. 1. Disorders of inflammation, steroids, immune suppression, cytotoxic. 2. Impaired perfusion. Prevention or resolution of problems can be achieved by turning off sympathetic activity, by correcting blood volume deficits, alleviating pain, and avoiding hypothermia. Wounds in highly vascularized tissues, e.g., head and us, heal fast and are quite resistant to infection. 3. Malnutrition. 4. Endocrine disorders. During rapid turnover, wounds gain strength and durability, but also are vulnerable to contraction and stretching. Fibroblasts provide the motive force for contraction. Receptors in fibrillous membranes attach to collagen molecules and pull them together when the cell membranes shorten as the fibroblasts migrate. The fibers are then fixed in the packed positions, probably by a variety of cross-linking mechanisms. Both open and closed wounds tend to contract if not subjected to a superior distorting force. The phenomenon is best seen in surface wounds, which in areas of loose skin may close 90% or more by contraction alone. On the back, the buttock, or the neck, this is often a beneficial process, whereas in the face and about joints, the results may be disabling or disfiguring formation of contractures or strictures. Skin grafts, especially thick ones, impede but do not totally stop the process. 5. Infection. 6. Radiation. 7. Foreign body. Thanks for listening and keep studying.